Dhana jana jovana garbham. Harati nimesata kalaha sarvam. What is the meaning? Ma kuru, do not do. Dhana jana jovana garbham. Dhan jan jovan let up proud no have. Ma kuru dhana jana jovana garbham. Harati nimesata kalaha sarvam. A kalbula bosu jitu asahi nimihota to Nike. So do not be proud of your valor, strength, power. So this is all meaningless in the time. Time is such powerful that it can finish everything. बहुत उत्साह अटालिका में एकदम बड़ा राजा बैठा था. Suddenly there was an earthquake. Within minutes everything is diminished. So do not be proud of your income. This is philosophy. So ma kuru dhana jana jaubana garbham harati nimesata kala sarvam. Hetu today's philosophy. Philosophy is the power. Anyway, we are going to talk about the replacement surgery today. Basic kotha to you supposed to know about the fracture in femur. Salient, we will talk the salient points particularly, not the theoretical thing, only practical thing. We already know about the fractures, different classifications. It is already clear. Yes or no? Anatomic classification is subcapital, cervical and basic cervical. Okay, fine. Then again another classification, Paul's classification, depends on the flexor line. More is towards the vertical line, more is the chances of shearing. And always, no more is towards the horizontal line, more is the chances of shearing. There is one of the principle of defined osteotomies. Yes. Osteotomies basically around the hip is basically to convert the flexor line from vertical to horizontal. So the same force which is working as a shearing force will now becoming a compressive force. McBride's osteotomy, one of the osteotomy which was popular in earlier days, in our days, was basically displacement osteotomy where you try to do this. ठीक है सर. Then Garden's classification is one of the most important classification, but it is true that there is limitation to it. It was only decided on the AP view only and only X-ray based. Nowadays thing is that the other part is not considered, like combination. Lateral view is not being considered, only AP view. Type 1, undisplaced. No. What is this? How do you learn? Trabecular. So you make out from the trabecular pattern is angulated. It's sometimes very difficult to diagnose from the X-ray, but you may need the CT scan to go for the diagnosis, confirm the diagnosis. Then type 2 is flexor, no displacement. Complete flexor, no displacement. Type 3 is complete flexor, partial displacement. Type 4 is complete. Type 4 and type 2 sometimes confuses because it becomes anterior-posterior X-ray, AP view overlapping, so it is confusion. So that is why he is not considering about the lateral view. So lateral view is important for what? For lateral view mostly. It's mostly to look for the posterior combination. Many times, what is the percentage? Around say 80 to 90% patients come with the combination of the posterior side and inferior. Posteriorly, here and inferiorly. This area is one of the vulnerable where the combination is there. One of the reasons behind is there, non-union is because of the combination. So that is why most of the time nowadays we do prefer for CT scan. Lateral view is also important, and for the this is flexor. Then vascular circulation, you know, we do not want to talk. There certain things are there which prevents the union in the flexor neck femur, but still says they are unsolved flexor. The terminology being very popular nowadays even though the technology improved, techniques are improved, better understanding is, even then we are facing a lot of problems with the flexor neck femur. Non-union is still, avian still a problem. Adamant type 1 becomes almost 30 to 40%, type 1 gardens also become displaced. So that is why the surgery is more important in all the cases, irrespective of the age, irrespective of the type of flexors. Because type 1 which is undisplaced one becomes displaced in 30 to 40% later on in due course of time. So that is why it is important to go for surgery. Surgery depends upon the various factors, not only age, also the morphology of flexor. That's a different thing and a type of surgery. Though there is so much evolution of the techniques. Initially, the Smith-Patterson nail was popular, very much. It's no more available in our days we have seen. Smith-Patterson nail is a concept by internal fixation. Smith-Patterson, SP nail. SP nail is not nowadays seen. Then comes the various types of screws techniques. Then again, morphology change of, then again you are knowing that some screws are coming from here to there, this side. This is also going to give a good support, but there is also problem with the subtrochanter flexors. So there is plus and minus. There is again lock plate concept is coming up. Lock plate is there, so as to prevent the collapse. 1 point. Number 2, there is again another plate concept is coming. What is this?
Middle plate.
Spider plate. Middle. Yes, because combination is there. To prevent virus and other thing, you can give a support here. So various combination, but basic principles are same. Few concepts about the internal fixation, few, not more. That we know that only flexion of human needs surgery, irrespective of age, irrespective of types. Even type 1 get complicated, get displaced during the time of treatment. You are going for conservative. Very lucky person may get united. That is why surgery is important. And depend on the selections of the surgery dependent on many factors, not only age, morphology factor. One very simple thing is that candidate for osteosynthesis. What you are going to do? Replacement. Even in young patient. So young patient who is coming late, there is absorption of the neck is not available, only head part is somewhere still very only very thin part is there, and this is absorbed. The reconstruction is not possible.
Yes.
If you do not have, how will you reconstruct it? So that is osteosynthesis concept is not there. So that is why the age is not a factor to decide the types of flexors, operation. Age is not it. Morphology of the flexor is also important. Quality of the bone is also important. How is the quality of the bone? It is said that osteosynthesis needs sometimes an unpredictable result, because failure is more so in case of osteosynthesis. Whatever it might be, whatever implants you are coming out, though there is comparatively some implants are, some techniques are better than that other, but even it is not absolute. Even when you are facing the low problem. Parallel screw concept is there, okay. Then a triangular screw concept is there to address the inferior, anterior and medial concept. ठीक है sir? Basic concept is that you must cross the flexor side with the threaded part. So if it is a flexor is there, you are passing a screw like this. So basic principle that I must select a screw who is, you know the size of the screw, 6.5?
Yes.
Canceller screw. Mostly we are going for your candidate one, so as to have a guider so that you can easily pass in the same thread. But basic principle that I must cross the threaded part here. The threaded part should not be in a proximal fragment. That is one. And that is why you can select the 16 or 32. Most of the time. Section 6.5, canceller screw, 6.5, 13, 16 and 32. You select. Suddenly, some people are coming up fully threaded screw also to prevent collapse. So there is combination, but basic principle is same. Then again configurations, whether you mean a reverse triangle or triangular. Reverse triangle is the posterior cortex, anterior cortex, inferior cortex, addressing it. That is a combination. Okay? Then again you are applying a plate over there, same thing. A new concepts are coming up. So same, basically same. But basic principle is remain same. Then there is another concept of Paul screw. You know the Paul screw? No. So Paul screw is saying, remember, you have to address from this side ahead. So Paul screw is more scientific. We are not using it, but it's supposed to be using it. Why it is more important that you know that in compression fracture, why you are addressing the compression screw, leg screw, this is basically leg screw. If the flexor line is like this, and the screws are passing like this, it is not perpendicular to flexor line. And most of the time it is saying that almost 60%, most of the patient the flexor line is almost 60 degree angle.
Yes.
Commonly. So these screws are not exactly same with that of the principle of that if you are applying a screw from here, ball screw, this side, this is going to cross the flexor side as the perpendicular line, and that is going to give good compression also from there. Screws from here and a screw from there. This is called pulse screw. So I am talking about the various types of internal fixation principle, not the techniques actually. Then again the concept is there to if you want to this is your fixation. Then morphology point of view you can go for the augmentations with the depth of muscle pedicle grafts and other things. In cases who is coming late, particularly young, but neck is still there. But here only fixes who is coming late. After 3 weeks he is coming, he is not a fresh case. But flexor is there, it is not absorbed. You want to do an internal fixation, sometime internal open induction may be necessary to reduce it. Then you are going to address not only the fixation, also biology. So biologically you can go for the muscle pedicle graft. So the Mayer's techniques is a bit difficult to do so in a posterior side. People are mostly using tensor fascial graft or sartorius graft here. This is basically two. This is more applicable for young. Suppose 30 years patient is coming to you, who is coming almost at 1 month after flexor. He is not a fresh case. So here only fixation may not give a predictable result. In this case, you may augment the biology with the help of this technique. Muscle pedicle can be done. It is not a very difficult surgery, but it takes time, but it can do it. This is basically for fixation, one, mechanical, another thing, biology. So address the biology also with the help of your, okay? So that is your internal phase. So then again, young patient you have to go for Moore spins, Knoll spins. These are basically to prevent the injury to the growth plate. Same concept, internal fixation, but you are not you are giving fixation without damaging the growth plate. This is for younger patient. So flexor and femur treatment is surgery. So selection of the surgery depends upon the age, morphology, flexor, other factors also. Even in elderly, very late patient, 90 year age, flexor neck femur type 1, very good, quality bone, internal fixation is logical one. Now comparing from the screws, various techniques of screws, sliding screws techniques is better, it says, compared to other. So whether we are going to parallel one, whether triangular one, whether log plate, whatever it might be, but sliding screw concept is better than that of your multiple screw. That you have mind? So nowadays that is why people are going for the DSS and derotation screw. Control collapse is there. DSS, then derotation screw to prevent the rotation. So this is concept is there. So compared to various types of screws, the sliding screw concept is better.
Sir, derotation screw won't prevent collapse.
Derotation screw is basically for what?
So to prevent the rotation while
rotation.
Yes,
so you have a round thing here. So SP nailing concept was a trifling. So it prevents rotation. But here the round part is going to give a rotation instability. To prevent it, we are giving another screw here so that it doesn't rotate. It helps in control collapse also. One. Number two is that prevent rotation instability. That is why people are using this. So our other combination and trial and error are going on. Even then it is true that even then we are not absolutely having a techniques which can give perfect 100% good result. Again after union also you may land up with the avian later on. Patient is been doing fine for 1 or 2 years, 3 years, fine. After 4-5 years he may come with the avian. Not uncommon. So these problems are always with the flexor and femur. But out of this it is said the predictable result is seen in replacement surgery. So replacement surgery is a good surgery which can give a predictable result, unlike the internal fixation. So predictably you can know that after doing surgery patient will have a good mobility and also locomotion. True? That is why people say, even it is said nowadays it is out of this, you know all the techniques are there. All the techniques you know. What are the balls, Moose prosthesis was very much popular. Mono. Bipolar is coming. we have a monopolar. So it is basically two. One is hemi replacement, one is total replacement. There is two only. In the hemi part, what are the things available with us? In a hemi part, what are the things available with us? Clean. What are the things available with us? One is your Moore's processes. So Moore processes was one of the time very much popular in earlier days. Nowadays, of course, winning up replaced by some other processes. Then again come in the Thomson processes. Thomson and the Moores were available earlier days. Thomson, you know, in case of Moore, you must have an integrity of the, particularly this. What is this? Calcar. It is resting on the calcar. If the calcar is not available, he is not going to rest on it, it will collapse and it will go for ferrous deformity. So that is why in those situations, earlier days, where the options were only for Thomson and the Moores, people selected for Thomson and address it with cement. As such, in in case of your Moore's processes, cement is not applied. But here in Thomson, cement is. Then again, modification comes with the bipolar concept. Bipolar, yes, coming up. You know, the bipolar, you have two joints. Advantage is there because you have the two joints actually, basically. Then again, we do have the modular bipolar. So bipolar has the limitation. Again, you have a fixed
neck size.
Neck thing. So do you know this part, neck is variable to person. But processes are fixed. M head fixed. Bipolar fixed type part. Modular is coming in the sense to address this part. So this is why it is more sometimes limb length discrepancy is another problem, particularly in case of the modular Thomson and the Moores. So to address this part, your modular concept is coming. So modular is more scientific in the sense that it is person specific. You are fitting this chart according to the size. Not a universal one you are applying, but you are fitting this tailor-made. So to extent you can say the tailor-made. So your device is that there is more biological, more logical to the person concerned depending upon his size and shape and angle. So that is why modular is better. Then again it is coming up with a total hip replacement. It is said, comparing to the bipolar, total hip is better here. Particularly in elderly patients, nowadays it is seen throughout the world that if you compare it to the situations, the total hip gives better result. So from functional point of view also. So you have a replacement size as such. If the AC double arm is okay, fine, people used to go for hemi replacement. But if the AC double arm is already somehow damaged, always logical to go for the total hip replacement. But AC double arm is okay, you have two options. Sometimes total, sometimes depending upon of course the person's choice and other things are coming up. Yes sir, so these things are there. So replacement surgery is going to give a better functional to the person. So people in those situations, elderly patients are suitable to go for it. So if a bedridden patient also, do you go for replacement? Yes, we do. Infection with the patient, it is going to help him to mobility. So in those situations, do you have your monopolar used or not used nowadays? Yes.
Yes, sir.
Yes. Any replacement with the monopolar processes, your Thomson and the Moores are still done in a terminal stage. Person who is not having a very long lifespan. So in this situation, one can go for the Moores processes. But who have a longer expectancy of life should go for replacement with a modular processes or total hip replacement. So even choice. So this judgment depends upon many factors. So that depends upon the person to person and also surgeon's comfortability. Other things are there. But now we are going to talk about the replacement, how we are going to do it. There are various techniques are there. Most of the time nowadays people are going for what? Moore's exposure was more used. Most of the surgeons Nowadays, but people are going for lateral and anterior. And anterior and lateral has got, anterior particularly, is in between the two muscles. The advantage in between two muscles. What are the muscles?
Sartorius and gluteus.
Achha. Now, in this plan, if you are going, so you are damaging less muscle. If your plan is correct, you are going straight way to the anterior aspect of the neck and you can go to the capsule. After all, you have to cut the capsule in both the conditions. Whether going for anterior or posterior lateral, that's it hardly matters. But thing is that if you are not going anteriorly, then what is the advantage that you are doing less muscle injury? On the other hand, if you are going posteriorly, you have to cut lot of muscles.
Yes.
Trauma is more, muscle injury is more. So, is there any option to us? Lateral. Hardings. Going from superior. So that popular easily became more. The hardings, of course, you have to cut. What muscle you have to cut? Gluteus medius. But it is a bit important thing is that gluteus medius is a very good abductor.
Yes,
so mechanics is very important for us. Whether sacrificing this is going to limb or that's very important because reattachment is very important. After all, if you are addressing from the posterior anterior here, you have to muscle here, this area. So either you can osteotomize this part or cut the attachment, reflect it. Okay, fine. Reattachment is important, but it is a very good abductor. So abductor mechanism sometimes compromised in this Harding's approach. Anterior is more scientific, but it is a bit difficult to do sometimes. Particularly hefty person. It is sometimes very difficult to find out the plane also. The muscles are very difficult to differentiate between these two. Some muscle axis is more important to differentiate, but it is more scientific. Now we are more convergent of doing what? Posterior. So we are going to talk about the posterior first, then we will talk about the other approaches also in a way. Now, in the posterior side, your patient is here. How the patient? The pelvis is there. Okay. The patient is like here. Now what is the position? Lateral. So you keep it, hold it like this. Now your hand is like this. So in this situation, patient is like this. So you have to give a support. That lateral is very important, particularly lateral. So fix it from the posterior post, anterior post, so that the stabilization there. The lower limb is left side is fixed. Now you are going to address this part. Yes, sir? Okay. Now this is the situation. Now how we are going to put the incision?
Sir, from PSI to GT and extend it.
Not exactly PSI. Actually,
Posterior lip of GT then extending towards the PSI.
in the line of PSI. Come down. So earlier days the concept is a forefinger. This is very interesting. Find out the tip. Now this is the position of the patient. We will talk about this. Here you will see here. So what is this muscle? Maximus. So incision is coming like this. Yes? Yes. So if the incision is coming like this, what is the axis? Find out the tip. Little bit of posterior is important, and the length, how much you are going down, and it depends upon the person's heftiness also. If the person is thin, probably it is more easy to do. Incision like this short. Yes? So if the person is very hefty, probably your incision will be a bit bigger. You can go down. So earlier this concept is there. This is PSI. In the axis of PSI tip. So one point is there, another point is here, another point is the midpoint. So people used to say the forefinger. So you have a Carolina incision like this. So you put the incision here. So this is the point. So extension of the injury is depends upon the size and comfortability of the person also. Thin person probably small incision will do. Hefty person you may need to extend down and up also. What next exercise we are coming across? The first size cut. Now this muscle is important. Where is the insertion is?
Vastus lateral.
Then this gluteus maximus. Tuberosity. So it is gluteus tuberosity. So you have to go through the muscle. So what is the technique of cutting the muscle?
In the line of fibers.
In the line of fiber. In the line of fiber, see the fibers are coming like this. So if your incision, separations of the muscles are important. Now if you cut this muscle here in the insertion part, and if you extend it upward, it will get less injury to the muscle. Starting from the tendinous part, and if you go like this, then you will find the muscle injuries less. But if you come in reverse way, you will find muscle injuries more. So always suggest you to go for the plain defined incision. Then you separate it, and you can do 2 fingers also. You can split it, or you can take the other force of whatever it might be to split. So that is going to give less injury to the gluteus maximus. But if you are coming from above, you will find your injuries more. There is one point. You have a detector. People are working for it. You also sunlight detector, or even sunlight detector. People are using. It depends upon this choice also. Detection is there. After detection, what coming? Here, while doing the incision here, you will get a what? In this area?
Trochanteric bursa.
Bursa. So sometimes you will, when you putting incision, you will find a little bit of fluid is coming out. The little bit of fluid is nothing but this bursa. Some bursa exercise. After the bursa, you are going to gain what?
Short external rotator.
Short external rotator. Not only short external, important thing after this area, you may get some sort of your fat and your soft tissue. Important thing is always take a sponge to delineate the entire movement. This is a very important thing. But do not, before cutting, you have to identify the muscles. The best way to do that, you try to separate this. So this pair of fat should be separated to delineate the muscles. Otherwise, you may not be in this zone, specific surgical zone. So that separation is very important. Go to the detector. Your nerve is somewhere here, where the medially. Yes, and your attachment area. Now, how do I identify the muscle? The best way to identify muscle is this.
Quadratus femoris.
So, if you identify the quadratus femoris muscle here, it is horizontal muscle. And in interesting point is no tendon is there. It is a horizontal muscle, no tendon is there. Origin muscle, insertion muscle, flat. Just like quadratus. Similar. ठीक है? Then just above this is a gemellum muscle. Then up to internus, gemellus superior, gemellum inferior, up to internus. Now, what is the top muscle here? Piriformis. So you will find the nerve is coming down the piriformis, and it is superficial to the extensor muscles. So this part should be delineated. Initially, you are supposed to delineate the muscle. Now, there are 2 concepts in there that people used to
expose the nerve.
No, exposure of nerve is not important. Do not expose, do not delineate with the nerve. Nerve is sometimes lying positive. You have a feeling, you can feel the nerve, but do not try to dissect the nerve. Do not handle the nerve. Nerve is far away, but you keep your eye always open that you are not going towards the nerve, and nerve should not be touched. Your exposure is somewhere here. Now working zone is what? The working zone is, this is what muscle?
Gluteus medius.
No. What is gluteus medius? And what is the muscle?
Quadratus.
Now your working zone is lying in between these two. Always make it clear that your working zone is lying in between these two. So you have to, that is why the limit should be there. I have the muscle here, I have this muscle here, and these are the short external rotator. My working zone is in between these two. So do not cross the limit. Sometimes you may need to cut your
Insertion of the
quadratus. That's a different thing, but initially, now there are 2 concepts. Somebody used to pass thread, suture, to like keep it in a stay suture sort of thing, so as that it helps you to repose the muscle back. opposite muscle bag. You can put a curved artery fossa beneath, between the capsule and the muscle. Beneath the muscle, superficial to the capsule. So you can stitch it, cut it and ligate it right. So this is going to have two things advantage. This muscle which you are threaded is going to help you to pull, so that it is a retractor also. ठीक है सर, retractor also. So next thing is in your capsule. So you have to delineate capsule and either T shape or L shape, whatever it might be. After you have to cut. After you have to. Next is the capsule. So after that you will get blood or fluid. Sometimes fracture, trace fracture, you will get blood is coming out. So that makes you happy that you are in the right zone. So fluid is coming out, the scientific fluid is coming out. So next part is what? Technical part. My biscuit is not there, no? Technical part we will talk. Up to this, some working zone is there. This muscle is very important. Beneath the muscle, you have the very important vascular structure. So if you are going down below, you have to be very careful. Otherwise, sometimes there may be profuse bleeding and the vessels may retract it back inside. That may cause a profuse bleeding. So that we have to be careful. You have a important vessels lying here.
Medial circumflex femur.
This is important. So that is why you have to be careful. Superiorly and medially, there are two things. One is this. Another is a nerve is there. Another, while splitting the muscle, the gluteus maximus, you have to be careful that you might be getting it in superior gluteus. This is another very important. Sometimes it may tear while doing the separation of the muscle, gluteus. Tearing of this vessel is another disaster. Because why? The vessels is coming from big part and it may retract it there inside. If it is going inside, it causes profuse bleeding inside and it will be difficult to control it. So you have to be careful in the extreme points. One this extreme, another this extreme, another is middle. So your working zone should be limited to this, where you do not have a very important structures. You have the muscles, you have the capsules, you have the other things, but you do not have the muscles. So extreme angles are different. One this, one your vessels here, another your sciatic nerve here. So your working zone is somewhere in this. Next part is almost mechanical one. So limit the head is there, flexor is there. This is flexor side. So there are various concepts is there. After there, people used to give two levers there. Levers. So as to delineate the neck. Now there are various concepts to remove it. Your torque extractor. Most of the time extractor is important. Put the extractor inside, take the head out. Or people used to put the lever like this. And lever is up. Now you have exposed this part. Flexor is here. Yes or no? Yes? Yes. So you need to do what? You have to extract out the head. Yes. Sometimes it will be difficult. Some displaced. If the fragment is going anteriorly, posteriorly, is very difficult. So traction may be applied. And even impacted flexor, you may so much time, you may face a lot of problems. In those situations, probably one part of the neck can be excised. Refashioning of the proper cutting may be take place later on. But for extraction purpose, you may need to excise this part. Sometime in impaction. And even your spike of the flexor may impinge inside the head. So it becomes sometimes so difficult to remove that you need to excise this part, middle part. Are you getting my point? Yes, some simple flexors are okay, fine. But if there is spikes there, it may hinge and that makes you difficult to. So you may need to sacrifice this spike to remove it. Yes, sir? So your flexor is coming out. So you can apply this your fork to put it inside and so this helps you out of putting. You need to do hammering inside. Because a round one hammer, then you torque. That will ultimately tear the what? Ligamentum teres. And one problem you are facing that sometimes you have liver there, so ligamentum teres is so strong, you may not allow it to come. So you may need to do sacrificing the leather with a curved scissor. Curved scissor can be applied to cut it. Then after head is out. So two things, one to measure the head, another is to properly cut the neck. Now how to cut? Two things, one head is there, so head can be measured with the help of this caliper. So you have to adjust what is the size. It is 45, or then you can go for the 43. Yes, so you have to measure it like this. Measuring, done, keep it there. Selection of the processes depends upon this. Now how to cut this part? You know you need a part from the calcaria. So basically, this is what?
Lesser
Lesser trochanter. So you have to expose this part. You have to see the lesser trochanter is here. People are saying that 1 finger breadth roughly, or 1.5 centimeter. ঠিক আছে? So here got templating. Templating is important. So we do not have the process over here. What is this templating? So you apply processes over here and look at the base of these processes and you mark over there with the help of a cautery. So this is more scientific than how much length we need to give. So you can place a processes over here. Yes? Then you give the mark. Cautery. Then you cut it. Roughly it is almost two things here. They is almost parallel to yes, parallel. 1 point. Almost parallel to it and almost perpendicular to it. So people say coming like this also. But whatever it might be, you must have a support there. And how much you are going to cut depends upon the length also. So that is why templating is important. So to determine how much neck I supposed to sacrifice and how much I supposed to keep. So roughly this is the your intertrochanteric case. You got almost parallel to it, 1.5 centimeter over the lesser trochanter. Now while cutting you have to be careful because your anterior capsule is lying like this. Your instruments are see capsule anteriorly. What is important structure lying anteriorly? Femoral artery. So femoral artery is maybe less protected. So while doing all this, particularly the saw. While you are using saw, you have to be careful. The saw doesn't incidentally go anteriorly. So if it is going anteriorly incidentally, some you are cutting and you are going deep. So you may cause disaster. So sometimes I suggest people to apply this Murphy's kit over here. Put it Murphy's kit. Why? So while I am cutting this the Murphy's kit is going to prevent to go incidentally going anteriorly or going this way that way. That is a simple technique I do myself sometimes. So that this saw is very, you have a very good control over the saw. It should not go this way that way. Yes, even inadvertently it is going anteriorly also because anteriorly you have the capsules and just anterior to the capsule you have the femoral artery. If it is going too much deep, you may cause disaster. So you have to be careful. One device is simple device I apply is there. Murphy's I do apply over here. Apply there and cutting it, I am very much safe. Says I am not going to cut anything beyond this limit. So it is going to hint, it is touch it, I will know that I am causing it. I have cut it and I have cut. That is the one thing important thing to do for protection purpose. So this is done. So next thing is there, we have to prepare the canal. So we do not have all the instrument. Canal finder. Canal finder straight remark is there, not here. We will put the canal finder. This part should be cleaned nicely. So as to find out the tip. And one most important thing is that most of the time the process placement is varus. Because if you are not lateralizing it, and offset should be clear. That is why this concept is there. You have to cut it like this box so as to lateralize it. Lateralization prevents varus. Very important. So otherwise if you are not cutting it, so necessarily head will be like this and it will be varus position and going to disaster. So the box is important to cut so as to lateralize it. That is why this part should be dissected nicely and see. Then you cut the head. Subsequently, you are going for your roots, rest. Define reps are there. Size is also available. Initially state 1 to channel canal, and even the canal diameter can be calculated with the help of canal finder. How much canal we are going to, what is the size? What is the size of the stem I am going to apply? So in case of modular process, you have this possibility with you, so that you have to like this. So otherwise what is the simple technique? This is tummy bar. So what is the importance of the tummy bar?
Anti-version.
How do you maintain your anti-temperature? So if I this is here, where is your no pelvis no. Keep it like this. The patient is like this now. Now your leg part is like this. So show me the leg part. So you see, I am putting inside. So it is parallel to the leg. This tummy part. Now it is parallel. If you want to do the anti-version, then I have to calculate from the position to I go like this. 15 degree. 10 to 15 degree. So this is being calculated with the help of the support. So limb is in fixed. So this is parallel to it. And from the A, you are making an angle of this. So this is going like this. So this is important. The tummy bar is important. Tummy bar is important so as to maintain the anti-version. Then rest of this, okay, you have to calculate the size. If the modular process, you have to do two things. One, after the insertion, so you may need to give sometimes cement, may not give cement. Depends upon, as nowadays people are preferring for cementless preferred. You have so many options available here. Cementless is preferred nowadays. So you have to select the processes. Size is determined with the sizer. So you have to select the size of the stems. Yes. Now length of this here, you have the option with you. Yes. You can maintain here. So length, how to determine? Trial is applied, and then you look for the
Movements.
1 point. Number 2, stability.
Shock test.
Or stuck test. Another is your tension. What is muscle tension? Are you okay? Pulling. You see how is the tension here? Is it adequate? Not adequate. If it lacks, then you have to go for the bigger size. If it's tight, then you have to go for small size. And again the length of the limb. So these have options. So that then inequality means leg length discrepancy is not there. So address this, you have this option with you, the size, the length size. You can select on the basis of the requirement on the soft tissue tension, stability, laxity, tight, and also the length. This should determine. Finally, you are doing the reduction, trial reduction, compare it, select the proper size, then put it. Finally, you have to resting it. Then again repair the soft tissue accordingly. Same. There is thread you have used. It can be used for some time. Sometimes in osteoporosis you can make drills here, small drill. So through the drill, if you are passing the threads, that is going to give greater anchorage. Posterior structure is very important because you have cut the posterior structure. This is a potential source. If you are not repairing it, you may go for redisplacement. Sometimes, to prevent it, you must repair the posterior structure nicely. Again, whatever you cut, you have to repose it. Hemostasis to be maintained, and close the layers in layers and with a drain. Now, in the transportation, you have to be careful. Better to keep the limb in the external rotation. So, external rotation prevents your headache. Flexion and internal rotation is dangerous. So, abduction and external rotations are good for the stability. So, transportation sometimes is very important. If you are not very careful, it may go redislocate. So, this is another problem. So, in the postoperative period also, you have to maintain it so that the person does not do flexion and adduction, particularly in intervention. This is going to be potential dangerous.